In the interest of time, I'll get us started. So, good afternoon, everyone. It is now afternoon. My name is Chell Miller. I am the program director in the Government Law Center at Albany Law School. We're very happy to have you all with us today. Very briefly, the Government Law Center has for almost 50 years provided nonpartisan analysis of pressing legal and policy issues facing state and local governments and we've provided opportunities for law students, attorneys, and members of the public to learn about issues facing state and local governments. This program will be focusing on maintaining access to New York's healthcare system in the face of federal uncertainty. This is part of our Warren Anderson legislative series, which has for more than 30 years featured experts addressing major legal and policy issues pending before state government. We're focusing on, what is at the kind of forefront of budget negotiations? What are legislators looking at? What are the kind of major issues that, New Yorkers are impacted by that are at the forefront of this discussion? We are very grateful to our sponsors. Our series sponsor this year for a contribution in the memory of Sharon O'Connor, Albany Law School class of 1979, as well as our program sponsor for today's program, Harter, Secrest, and Emery. Thank you very much. That support helps us do the kind of work that we want to do. Before we dive into things, I want to share some notes from the team here. For attorneys looking for continuing legal education credit, you received your CLE forms and program materials by email. Those forms will need to be completed, signed, and submitted to my colleague Lisa Rivage within 24 hours by email. I'll put her contact information in the chat, but you should have received that by email as well. For those of you with pressing questions about New York's healthcare system and access to healthcare, we will have a Q&A session at the end of the program. Please type your questions in the Q&A box. We have over 270 people registered for this program, so we will not be able to get to everyone's questions, but we will do our best. And finally, we have captions for this program. To view the captions, you can click View Transcript or show captions or show subtitles at the bottom of your Zoom window. We are also recording this program, so it'll be accessible for later viewing. And I'm really excited to, pass things over to our moderator, Amy Kellogg, who is a partner at Harter, Secrest, and Emery, and chair of the Government Law Center's advisory board. Thank you so much for being here, all of you, and let's get this going.
Great. Thank you, Chell. Appreciate it. When we put together the topics for the CLEs, it's always interesting to try to figure out what may grab people's attention. And I think we were all pleasantly surprised to see that with the number of participants on this program, clearly the healthcare topic is an important one. So we're excited to put a spotlight on that today and to talk about maintaining access to New York's healthcare system in the face of federal uncertainty. So as Chell noted, I am Amy Kellogg. I'm a partner at Harter, Secrest, and Emery. I'm head of the Government Affairs Practice Group. And I'm honored to be moderating this panel with my three esteemed colleagues who I've worked with in various capacities over the years and harass most of them pretty daily. So excited to be doing this panel with them. And, when you look at the title of this program, it's pretty broad, right? So what we're really going to focus on and drill down into today is the impacts of HR 1 on New York specifically. And even that is still too broad a topic. So we're going to cover what we can while we're here, and each of our panelists will sort of bring their presentation to that. But I think we wanted to just kind of level set really quickly before I kick it off to our panelists to talk about HR 1, because we all forget we live, eat, and breathe this, and we assume that everyone's paying attention to all of this policy and all of the implications of it like we are. And it turns out that other people don't focus on this in the same way. So we wanted to just kind of take a second to talk about HR 1. And the other thing that's really interesting about HR 1 is that it was in the news a lot last July when it was first being discussed and implemented at the federal level. And I always find it very amusing that it's referred to as a tax bill, right? It was dealing with tax credits and had nothing to do with healthcare. So why was everyone paying attention to this tax bill at the federal level? And really, I mean, it was couched as a tax bill. It was a reconciliation bill at the federal level, implementing sort of the budget provisions of some of the federal tax policies. But one of the most significant pieces, I think, of that bill was really the impact it was going to have on healthcare. And you all, in the materials for today, there are lots of materials. But what I wanted to do was just sort of take a second to look at the numbers, the HR 1, the impact on New York, to kind of level set and give a little bit of, why are we talking about this and how does it impact New York and how can that be a whole topic? And I think that we start with sort of looking at the annual funding cut to New York based on HR 1. And again, I'd love to give you one specific number on this, but there isn't one because, it depends on the analysis and how certain policies actually get implemented. But in any estimation, if you look at it, 7.5 to 8.4 billion is the estimated range of direct impact funding cuts to New York. And that's sort of the direct is the key word there, right? The direct impact to New York, because those are the numbers that New York will lose in funding across the board for when you look at the different programs. And that's not the only impact, though. There'll be drilled down impact from there about facilities and different programs that exist that also will see their own impact, which is not technically state cuts to funding, but obviously if that funding is cut, the state will be looked to help fill that gap to some extent too. So conservative numbers, 7.5 to 8.4 billion annual funding cut to New York. So what that also means is that as of July of this year, 450,000 New Yorkers will lose all access to healthcare coverage. And the state is looking at different alternatives, but at the end of the day, there's only certain things we can do at a state level. These are really federal decisions. We also will have 2 million New Yorkers who are going to be looking at biannual renewals of Medicaid instead of the current annual. And for any of you who have ever touched the Medicaid process and know what that's like, the yearly renewal is difficult enough for families. Having to do that twice a year now is going to have impacts not only on Medicaid patients trying to access the services, but the hardworking men and women in New York who actually implement the program who are already, there aren't enough of, and there's already challenges there. So we're going to see some of that as well. We're also going to see 1 to 1.5 million New Yorkers lose Medicaid coverage because of new work requirements that were put in place under HR 1. So, again, don't know the full impact of that, but that's the conservative number is that at least 1 million to up to 1.5 million people will lose coverage. Also included in all of this is sort of, I guess we could consider it healthcare adjacent, although I think food security and access to food is part of healthcare, but we're going to have 40,000 New Yorkers who are going to lose access to SNAP benefits. So under the new rules, it changes who can be eligible for those benefits. 40,000 New Yorkers will lose that. And, that's sort of just the beginning, if you will. We also have 1.6 billion loss of state revenue from the elimination of the MCO tax, which was implemented in New York. So the legislature will be looking at how to implement that. We also will have $200 million in funding, reduced federal funding to those SNAP benefits that I had talked about earlier. So I'd love to say that there's a silver lining to this, and maybe that's a question I'll save to the end after we have our panelists go through everything. But it's going to be a significant impact, and it's not going to be one that's not felt by anyone who sort of relies on healthcare in New York, including those who don't rely on Medicaid or state-based health insurance. It's going to have rippling effects through all of healthcare. So with that super fun intro and level set of HR 1 and why we're talking about HR 1, right? Not just a tax bill, wide-ranging implications for healthcare in New York. One other comment I do want to still make is when we were putting together this breakfast, the state budget was going to be done by now. And for those of you who follow this, it's not quite done yet. We're in overtime. So there are some budget actions that are pending. And I'm just going to throw out there that, we, as Chell said, please ask your questions, but I will say that any questions related to the state budget, we're just not going to be able to answer, and we're not going to be able to opine on them either. Negotiations are still happening. We just don't have enough information yet. So I did want to just let folks know that we are still sort of assessing what the state's full impact will be. But what our panelists are really going to focus on is, what are they, regardless of what the state does, what are the impacts of HR 1 and what does that look like, and what are sort of the red lines they're looking at addressing. So I wanted to just throw that out as a little bit of a level set that we don't have the final budget yet. And I guess to say at a high level, maybe something that I'm the only person on this level that can say, even if it was a perfect world, New York can't cover this, sustain a hit all on their own. There's going to be some practical implications that even in the best case scenario, the state is going to be unable to sort of fully address. So there's going to be a lot of creative thinking happening, and the private sector is going to have to play a bigger role than ever in healthcare for a variety of reasons. So we'll dig into all of that as well. So with all of that fun, Erin Kay, I'm going to let you start us off. So for those of you that don't know Erin Kay, I had the pleasure of knowing her for a very long time. We were law school classmates, but Erin Kay is currently senior counsel for Governor Kathy Hochul, and she works primarily on healthcare issues. And that is the least flattering introduction ever I could give her, but I'm going to kick it to you to give a better introduction and share your thoughts to kick us off. So thank you.
Yeah, thank you, Amy. Appreciate it. Good morning, everyone. Afternoon. I am Erin Kate Kalicki. I'm Senior Counsel to Governor Hochul. And in my role, one of my responsibilities is legal oversight of the New York State Medicaid program. So my goal today is to outline the significant regulatory and legislative shifts that are occurring at the federal level and the anticipated effects it'll have on New Yorkers. This session of this series is definitely aptly named, as we are indeed currently operating in a period of federal uncertainty driven by the enactment of H.R. 1 last July. But before diving into the shifts that are occurring, I'll give a brief overview of the current landscape of Medicaid in New York. New York has always led the way in Medicaid as it pertains to coverage. We have always created a continuum of healthcare options with Medicaid as the foundation. New York also has expansive Medicaid state plan benefits, things like school-based mental health, nutrition, housing, transportation, doulas to support birth outcomes. Our benefits are expansive, but our eligibility limits as a percentage of the federal poverty level are right in line with the national median. As of February 2026, there's approximately 6.7 million total beneficiaries enrolled in Medicaid. About 57% of those are in New York City and 43% in the rest of the state. And New York heavily utilizes managed care to deliver our Medicaid benefits. About 70% of the population is enrolled in Medicaid managed care, with the remainder in fee-for-service. So I will focus a little bit first about the shift in at the federal level. The federal focus around Medicaid has now shifted to rooting out fraud as the centerpiece of its healthcare agenda. In January 2026, the Department of Justice established the National Fraud Enforcement Division to centralize and intensify prosecutions related to healthcare fraud schemes in federal programs, including Medicaid. Even more recently was announced the Comprehensive Regulations to Uncover Suspicious Healthcare, with the acronym CRUSH initiative, led by Vice President Vance and CMS Administrator Dr. Oz. It utilizes AI-driven detect and deploy strategies to stop payments before they are issued. And I'll talk a little bit about how New York addresses fraud, waste, and abuse in Medicaid. To summarize, we address fraud, waste, and abuse systemically and by using a multi-layered approach. New York has a robust system that coordinates multiple agencies to protect these taxpayer dollars that fund Medicaid. All of the agencies work closely together. They make referrals and recommendations to each other as is needed. But four of the agencies that are kind of the most crucial to the stopping fraud, waste, and abuse and dealing with it in New York are these. First, the Department of Health, the New York State Department of Health. Every state is required to name a single state entity that's responsible for administration and oversight of its Medicaid program. And in New York, that is the Department of Health. We also have the Office of Medicaid Inspector General, which is the central enforcement authority for Medicaid program integrity. New York is one of only 3 states that have an Office of Medicaid Inspector General devoted solely to Medicaid program integrity. Third is the Medicaid Fraud Control Unit of the New York Attorney General's Office, the largest unit within the Attorney General's Office, and called MUFUCU, which is always a funny acronym to me. MUFUCU is responsible for investigating and prosecuting alleged violations of state law related to fraud that are connected to Medicaid. Every state has a MUFUCU. New York's is one of the largest. And finally, the Medicaid managed care organizations themselves, who are responsible for having special investigations units within their MCO, auditing, investigating, reviewing its own claims, and making referrals. But the bulk of time, I really want to focus on the impact of H.R. 1 on New York. And that is just an absolutely huge topic, as Amy noted. So I will just touch on 4 areas that are either causing or will cause some significant stress on New York's Medicaid program. First are the changes related to the essential plan. which in federal law is called the Basic Health Plan. There's two major federal changes last July that are impacting marketplace coverage in New York. First, there were reforms that restrict premium tax credit eligibility. And second is the expiration of the enhanced premium tax credits. The collective impact of these changes resulted in the need for a significant coverage shift for us in New York. Since April of 2024, New York has operated its essential plan under an Affordable Care Act Section 1332 state innovation waiver. This allowed expanded eligibility up to 250% of the federal poverty level, which is a change from the standard under Section 1331 of the Affordable Care Act, where the essential plan was before that, and allowed for eligibility of up to 200% of the federal poverty level. Federal funding for the essential plan is tied to the premium tax credits that eligible consumers would otherwise receive towards qualified health plan coverage on the marketplace. And the changes of H.R. 1 cut that federal funding in half, which made this program unsustainable for us. We took immediate action in New York to seek approval from the federal administration to move the essential plan out of the 1332 waiver and back to the program under Section 1331. By doing that, 1.3 million essential plan enrollees will keep their coverage and will have no change in the level of benefits or their coverage, no gap in coverage. However, we did have to send notices on April 1st to around 450,000 essential plan consumers, which represents those between 201 and 250% of the federal poverty level, to inform them that their essential plan eligibility will end effective June 30th this year. The next area that's affecting New York significantly has to do with the MCO tax. New York currently has an assessment on insurers and managed care organizations. The purpose of it is to raise state revenue and secure matching federal funds that are used to support hospitals, nursing homes, and other types of providers. State Medicaid programs are required to provide at least 40% of the non-federal share, and they can do so through several ways. One option is through revenue from a healthcare-related tax. Healthcare-related taxes are required to be broad-based, meaning they're generally applicable to an entire class of healthcare items and services or to providers of healthcare items and services. And they must be uniform, meaning they're applied at the same rate to all healthcare items and services or providers in a permissible class. If a tax is not both broad-based and uniform, the state must seek approval for a waiver of the applicable component or both components, as the case may be. New York's MCO tax was approved by CMS in December 2024. It consists of a tax upon health plans, which includes Medicaid MCOs, essential plan insurers, and other commercial health insurers on a per member per month basis. In late January 2026, though, just a little over a year later, CMS issued a final rule on the topic of healthcare-related taxes. And as per the final rule, New York's MCO tax will not be permitted as of January 1st, 2027. This has an immediate impact on New York's Medicaid because pursuant to state law, the uses of the MCO tax are limited primarily to provider rate increases. And the penalty for using an impermissible healthcare-related tax as non-federal share of Medicaid expenditures is significant. Prior to calculating federal financial participation, or called FFP, the Federal Health and Human Services will reduce the state's Medicaid expenditures by the sum of any revenues from an impermissible healthcare-related tax. The third area I'll address quickly are state-directed payments. State-directed payments are mechanisms that allow state Medicaid agencies to require MCOs to pay their contracted healthcare providers at specific rates or by specific methods. New York uses them for a variety of reasons, including to strengthen access to care for Medicaid beneficiaries by closing the gap between our taxpayer-funded Medicaid payments and the actual cost of care, primarily for our safety net providers. H.R. 1 allows existing state-directed payments to stay in place, but it would freeze the annual amounts that are paid. It limits the level of all new state-directed payments to 100% of Medicare rates. And if no Medicare rate exists for a specific service, the cap defaults to the approved Medicaid state plan rate. Legacy state-directed payments, meaning those that pertain to a rating period occurring within 180 days of when H.R. 1 was passed, and for which the state has either received prior written approval or submitted a good faith completed preprint form before a certain date. Those legacy state-directed payments can maintain their higher rates for a limited time. Beginning January 1st, 2028, they must gradually phase down through a reduction of 10% annually until reaching the Medicare payment limit. And the last topic I will quickly touch on are the community engagement requirements of H.R. 1. H.R. 1 establishes the first ever national community engagement requirements, which are also referred to as work requirements for Medicaid recipients. The law shifts Medicaid from an income-only eligibility model to one that requires non-accepted adults to demonstrate active participation in the workforce or community to maintain coverage. Applicable individuals must complete and document at least 80 hours per month of qualifying activities. This could be traditional paid employment, self-employment, community service in the form of volunteering for a nonprofit or a public agency, or enrollment at least half-time in a university, a vocational school, or a job training program. The requirement is automatically met if the individual's monthly income equals at least 80 times the federal minimum wage, which is roughly $580 per month. In New York, though, about 71% of our Medicaid beneficiaries, adults, are working. Full-time is 44%, part-time is 27%, and those who are not working are only 29%. And that includes people like individuals with physical or mental disabilities, postpartum women, primary caregivers of dependent children or other disabled household members, and those who are medically frail or have a substance use disorder, or full-time students. The Congressional Budget Office and independent analysts have projected that nationally, somewhere between 12 and 17 million people will lose Medicaid coverage over the next decade due to either non-compliance with the work requirements or administrative churn, meaning paperwork hurdles. Notwithstanding that this doesn't seem to be a problem in our state, having people working, New York will, of course, comply with the work requirements. But this will not save us any money. Instead, it will carry a cost. We have a large and robust Medicaid program, and we need to build the programs to track these new requirements. One could reasonably argue that these costs would be better spent providing care to those who need it. And with that, I will turn it back to you, Amy, to introduce the next. Thank you.
Thank you, Erin Kate. And yes, everyone, happy Monday. We're full of good news today. So Sarah, I'm going to turn it over to you now. Sarah is the Executive Director for the New York State Association of County Health Officials and is going to kind of walk us through the federal impacts from a public health perspective. So Sarah.
Yeah, thank you so much, Amy. It's really a pleasure to be on this panel with esteemed colleagues. And I'm really speaking from the prevention standpoint of things. And to really get into this, what I need to do is I need to backtrack many decades to give you a little bit of a history of how public health has evolved in New York State over time. And historically, local health departments, 20 years ago plus, played a more direct clinical care role in New York State They were doing things like going into homes, providing in-home care services, testing, monitoring, providing treatment. They were doing, family planning services. And in the late 90s, early 2000s, there was really a deliberate shift, which was influenced by state level policy, the emergence of the Affordable Care Act, Medicaid reform efforts, really toward a model more focused on population health, prevention, and epidemiology, rather than local health departments providing those direct clinical service delivery models. And so moving forward to today, what public health looks like is local health departments make up our local public health infrastructure across the state. We work very closely, of course, with the State Department of Health, but we continue to lead critical life-saving work. But most of our local health departments today no longer operate primary care clinical services. Instead, they're going to be offering more limited community-based clinical services, so things like immunization, health education, cancer screenings, and referral to care services in the clinical service system. And, thinking about what that looks like in rural areas, some local health departments in cooperation with their county leadership have decided we're still going to provide some clinical care services like dental care, home health, family planning, because there's a service gap need and there's a lack of providers available. So those services are typically existing in local health departments or counties where there are, pretty broad gaps in the healthcare delivery system, and there's going to be limited provider availability. So every local health department looks a little bit different in terms of the services it provides, but the evolution is really important context when talking about HR 1, because we have to consider the potential local impact of federal actions, particularly those impacting and affecting health insurance coverage and access to care. New York State, and the reason for that is because when there is a public health emergency where you need a large number of clinical care providers, it can be challenging to rely on our local public health infrastructure for that, like we once did, because those staff are no longer there to do the clinical work. New York State is also one of very few states that pays a local share of Medicaid costs. While in New York State, we have a property tax cap that's outside of New York City, those expanding medical costs really impact local ability to provide services, because when you see increased costs locally, local agency budgets compete for revenue from tax funding. So we're really grateful to our colleagues at the New York State Association of Counties, led by Stephen Aquario, who manage these discussions within counties. But when you're thinking about this, you think about, local health departments aren't the only local service that needs, resources to provide support to communities. You could be thinking about law enforcement, parks and recreation, social services, offices for the aging, and so many others that are relying on some kind of source of local tax funding to do a little bit of the work. And really, the changes that increase barriers to insurance coverage for access of healthcare may create additional pressure at the community level. Local health departments, however, generally do not have the capacity, workforce, or funding to resume that broad clinical service role right now. Now, don't get me wrong, local health departments are really good at working on an efficient amount of funding to do what they need to do to fulfill their core public health responsibility needs, to take on new mandates, as long as there's funding there to provide that. They're really good at doing this work effectively. But we just like clinical care organizations are seeing a loss in our workforce. Our association, the New York State Association of County Health Officials, that represents local health departments across New York State, we conduct an annual workforce enumeration study. So this study, over time, we have about 4 years of data with us right now that we can compare. It does show that over 90% of New York's local health departments report being understaffed, making it challenging to deliver core public health services. And that is based on a national model out of the de Beaumont Foundation that we were deriving that information from. There are key specific positions that are also very challenging to hire. Nursing staff is certainly one of them. One of the challenges there is competing with direct clinical care services in terms of salaries, benefits, and then environmental engineers and regulatory inspectors. So those are folks that are going out into the community and inspecting restaurants, making sure that, tobacco retail sites are not selling illegal products like flavored vape products that appeal to children. So those are really key roles. If there's a statutory requirement for local health departments to regulate, we need people to be able to go out and actually do that work for that law to be effective. The other difficult position to hire is business administrators, surprisingly. So financial staff, because so much of local health department or public health funding comes from the CDC or other federal agencies, it's passed through New York State to local health departments. It's really important that we have those staff with business acumen or financial acumen to be able to administer those grants appropriately. And then despite these constraints, local health departments are really resourceful and they continue to deliver essential evidence-based services. So as policy changes are considered, there's definitely an opportunity to further invest in prevention-focused strategies that reduce hospitalizations and improve long-term health outcomes in New York State. And at the same time, ongoing discussions at both the federal and state levels include proposed reductions to public health funding streams. So while we're thinking about HR 1, and Amy covered how much money is at risk here, these reductions to public health are really going to have a drastic impact on hospital systems and the economy of our communities. And it's going to certainly create a challenge. When funding is constrained, local health departments often experience the greatest impact due to limited flexibility in local budgets. And funding local public health agencies, supporting prevention services. These are the services that really drive economic value. They create jobs. We work with hospitals and federally qualified health centers and other clinically focused systems by preventing avoidable hospital admissions and strengthening our public health infrastructure. So while all of this change is happening within HR 1, and people are losing potentially access to clinical care services, we need to think strategically about funding prevention, continuing to support our local public health system in order to reduce the burden on our hospital partners. Amy, I'll turn it back to you.
Thanks, Sarah. I appreciate that. And yeah, I think you raise a great point about what I was talking about. The impact is, that's just the straight federal dollars to the state, right? That ripple impact is going to be significant. So before I turn it over to Stephanie for continuing of the good news, we're going to take 1 second to do a bit of business. So, Chell?
Yes. So for those of you who are attorneys on the call today looking for CLE credits, you have one code that you'll need to record on your form. That CLE code is 71301. Your CLE code is 71301. Thank you.
Thanks, Chell. All right, everybody got their code? If you didn't have a pen, one more time, 71301. All right, so we're going to move to our third panelist, Stephanie. Stephanie is the Vice President of Government Affairs for Haney's, and Haney's is the Healthcare Association of New York State, for those of you that don't speak acronym like those of us in the space tend to. So Stephanie, I'll kick it over to you to talk about this impact from a facility point of view.
Sure. Thanks so much, Amy. And thanks, everybody. I'm really pleased to be here today. For those of you who may not be familiar with Haney's, we are a membership and advocacy organization that represents nearly all the state's hospitals and nonprofit nursing homes. In my role, I help oversee our state advocacy efforts. So before I get into the specific impacts of HR1 on hospitals and nursing homes, and Erin Kate covered a lot of this. That's always the benefits of vetting cleanup. Some of this stuff is covered before you get to me. I do want to take a step backwards. In healthcare, there is a term called acute on chronic. And so it's when somebody's living with a long-term condition and suddenly they get hit with a serious unrelated problem that makes everything worse. So unfortunately, that's a phrase that we've been using lately to describe New York's healthcare system. So for years, the state's healthcare system has been dealing with a number of longstanding challenges. And Haney's has done some work on this. We had a white paper, if you will, called The Case for Change. And it looked a lot of data, and it showed that there are really 4 drivers that are pushing the healthcare system towards what we were calling an existential cliff. And I don't think any of these will surprise. I know they won't surprise my colleagues on this call, and they probably won't surprise many of you. But the demand for care is growing and changing. We have a rapidly aging population who will need more healthcare services. The healthcare workforce can't keep up. We don't have enough healthcare workers, and we don't have the right healthcare workers for the way healthcare is going to move, the types of illnesses people will get and the conditions. Health disparities persist and are widening. And then affordability remains a real challenge for everybody, for consumers, for employers, for payers, and providers. So none of those things are new. They've all been building. But then on top of that, we had this new acute shock, and that's the enactment of HR1. And so as Erin Kate shared, there are so many provisions in HR1 that over the next 8 years will pull back federal healthcare support for New York. Coverage will be limited for many New Yorkers. We talked about the essential plan changes. There are reimbursement rate cuts for providers and health systems. We've talked about things like the workforce requirements, the recertification, the loss of MCO tax revenue, the state-directed template payments. So there are just so many different hits. And for hospitals in particular, the numbers are pretty staggering. And we've done some work with some of our other associations. And right now it looks like for this year, hospitals are looking at a $1 billion hit, which is a lot. It's definitely a lot. But hospitals, when all of HR1 is fully implemented, we are estimating the hospitals will experience between an $8 to $10 billion hit every year. And over time, building up till 2023, that'll be a $40 billion loss to hospitals in New York State. So the numbers are staggering. Unfortunately, I'm not the one with good news in this part of the presentation, but I will say we were really pleased, and I know we're not talking about the budget today, and the budget's obviously not has not yet been enacted, but we were really pleased that both the governor and the legislature really acknowledged the magnitude of the impacts of HR1 and other damaging federal policies that we may hit on a few of them this afternoon. So we really appreciated that there was this long-term commitment with multi-year funding for hospitals and nursing homes. We sort of took some time between July when the law was enacted and the beginning of the legislative session to take a look at what are some policies and proposals that we could try to advance to mitigate the impacts. And outside of investments, which obviously are very important, there were things that we were kind of referring to as the common sense proposals. And those are things like managed care reforms. You know, a lot of times providers will provide the service and then wait to get paid, and claims are delayed and denied. And it creates cash flow problems and all kinds of problems that if reforms were put in place and providers were paid more quickly, there wouldn't be such financial strain. And again, I want to thank the governor because she included a number of managed care reforms in the executive budget. The other area that we've looked at, and I know, Amy, this is dear to your heart, and Sarah, you talked about it a little bit from your perspective, from the county health perspective, but workforce. We have real challenges when it comes to workforce. And it's sort of a two-pronged thing for us, that we've got these workforce shortages that we have to deal with right now, but then there's also, how do we create a sustainable pipeline? And lots of issues around having enough facilitators and instructors. But something that we've been focusing a lot on in the near term is a frustration that we have. And again, Amy, I know you can relate to this, that there's so many highly trained healthcare professionals that can't fully use their skills because of regulatory requirements. So that's another area that we really are trying to advance some proposals. And again, I feel very complimentary towards the governor today, Erin Kate, but that's also something there are a number of proposals that the governor included in the executive budget that would provide workforce flexibilities. We'd like to go a little bit beyond that with things like allowing CRNAs to practice independently and some other professionals, because we're seeing a workforce crisis really in every position. We'll often get asked, is it just nurses and doctors? And no, it's every tech that you can think of. And we've got to continue to be creative and figure out how we deal with the workforce shortage, not just today, but, in the years to come. So those are just some of the things that kind of keep us up at night. And I know my colleagues on this call can relate to that. And HR1 just made it all worse, bringing it back to HR1.
Thank you, Stephanie. So that sort of concludes the formal presentations, if you will. So I say that to remind everybody that there are, the Q&A is open. So if you have questions, throw the questions in there and we'll get to what we can. And assuming that they are not super political, because I will note that we are not going to answer anything super political because we can't, frankly, but also, we're just talking about the actual practical implementations of policy. So that's where we're going to keep our focus. So while I'm letting you all parse through the questions and see what questions are there, I guess I can start with one too. I think going back to maybe the workforce development issue a little, and something that maybe you all can hit on a little, is that I'm always surprised at sort of what captures public attention and what doesn't. And I'll take the public attention, but sometimes it's not going exactly where we thought. And I think the best example of that is there was a lot of, and maybe it's just because I represent the nurses in New York, the American Nurses Association and the nurse anesthetists in disclosure, but it was a big hubbub, especially on social media, about the student loan changes that were also included in HR1. And I think that it's interesting as we talk workforce development, what we hear universally is there is a shortage of healthcare providers across all specialties. You name a specialty, we have a shortage of that provider. So I'm curious, if that's factoring to any of the conversations you all are having as well, because for those who aren't familiar, in HR1 at a very high level, I think that there was an attempt, and I think it was a well-intentioned attempt, but policy is complicated, right? There's many moving parts. There was an attempt to decrease the burden of student loan debt on those who are pursuing degrees in higher education, which is a laudable goal. However, that goal is better accomplished when the price of the underlying higher education is addressed, not just capping maybe the amount of loans that students can take, but there is real concern that it's going to have a chilling effect on folks who are attempting to get their degrees in these higher education areas related to healthcare, because if you cap the amount of student loans that people can get, they can't afford the cost of the education. So what does that look like? So I don't know if any of you have sort of flagged that or wanted to add anything on that, but I think that all of the workforce development issues you've highlighted sort of feel compounded by that as well. And I'm bringing that up because I think it was interesting that seemed to get a lot of attention on social media and was one of those things that people hadn't paid any attention to because a tax bill passed last July. What does that have to do with student loans? So I don't know if anyone wants to add anything on that. Feel free, and I'll see what questions we're getting in the chat as well.
Amy, I'll just say that we are hearing from our members that is something they're gravely concerned about. it's interesting. We do a fiscal survey every year to get a sense of how our systems are doing. And some of the questions we ask in the survey are related to workforce. And in this last survey that was done in November, it showed that hospitals' overall labor spending had gone up by 23% since 2022, outpacing inflation by 9%. Yet at the same time, hospitals are still struggling to fill vacant positions, with 8 in 10 respondents continuing to report shortages of nurses and other personnel. So anything that is going to make it more difficult for individuals to enter the healthcare workforce, it's a real concern for us. And my colleagues on the federal side for Haney's are continuing to push back on this, and also changes to the H-1B visas, that there would be a new $100,000 fee tied to those. And I know they're trying to advance legislation on the federal level that would exempt healthcare workers.
Yeah, and from our perspective, when we have candidates applying for local health department, local government jobs, we absolutely use public service loan forgiveness as a incentive to come over to the job. And so any changes to loan forgiveness programs is going to be a challenge for us, because we're going to see those candidates looking for higher salaries that, it's not always feasible depending on what the job is, if it's an entry-level position at a local health department. So definitely something we need to monitor and keep track of. And then, yes, there have been many medical students that have reached out to me with concerns about this. And that means fewer medical candidates, fewer clinical experts looking to come work at local governments unless we're offering the right benefits and salaries. So,
Great. Erin Kate, I don't know if you want to add anything there. I'll just know, I will say the governor has been very good focusing on workforce development initiatives at the state level too. So I think that was already a focus, but we're going to need more of that, it sounds like. So stay tuned for that. So we do have questions in the chat, so I'll start going through those. And I'm going to start with one, Stephanie, that's directed specifically to you. Are facilities expecting to handle more emergency care from uninsured patients because of the loss of coverage from HR 1?
Yeah, absolutely. And if I will, I'm going to try to do this. I'm terrible at sharing my screen, but I do have a graphic that shows the uncompensated care. Can you guys see it?
You're sharing. It's there. Yep, there it goes.
Oh, there we go. Okay. So again, we put this together with the Greater New York Hospital Association to show the cascading effect of HR 1 over the next 8 years. And if you look down, moving down, there is a huge hit from uncompensated care and cuts to the essential plan. The bottom line is people may lose coverage, but they will not stop getting sick, and we will not stop caring for them. So this is a serious concern to our members.
All right, so then our next question, if you can answer, some of these I'm not sure we can answer, but one attendee is asking, they've read that work requirements only apply for expansion adults. Don't expansion adults already need income to be expansion adults? So wouldn't they qualify for work requirements anyway? Erin Kate, yeah, I see you nodding. I'll let you take that one.
Yeah, I can take that one. So the term expansion adults refers to the Affordable Care Act, which provided that states could expand coverage to certain adults. And, prior to the Affordable Care Act, federal rules limited Medicaid to specific categories: children, pregnant women, the elderly, and people with disabilities. Low-income adults without dependent children were excluded and couldn't get federal help for Medicaid. However, in New York, as we have always sort of led the way for coverage, as I mentioned, New York did have a federal waiver prior to the Affordable Care Act that allowed it to cover single adults and childless couples with incomes up to 100% of the federal poverty level. So in New York, the definition of expansion adults are those single childless adults who are between 100% and 138% of the federal poverty level, because we were already covering adults under up to 100% before that. So that is what we refer to in New York as the expansion population. And it is that expansion population that will have the work requirements. And so, yes, they will have some income because they do have income as a percentage of the federal poverty level, like all beneficiaries. But they have to show that they have enough monthly income that is 80 times the federal minimum wage. So approximately $580 per month. And that is what the work requirements will have to be done and documented as a condition of getting Medicaid eligibility.
Thank you. Sarah, a specific question for you. Can you speak to the potential impact of HR 1 on local health department staffing, technology systems, programming, and administrative workload, and what resources the local health departments may need to absorb those pressures and avoid unintended consequences?
Yeah, absolutely. You know what? Let me maybe give something more positive. Can we talk about the rural health transformation funding? Because that is definitely something on the horizon that could have potential positive ramifications for local health departments. While local health departments aren't receiving rural health transformation funding directly, there's $212 million out to New York State on from this program that is going to focus on things like community integration models, technology and innovation in primary care, building a sustainable rural healthcare workforce. So the key here is really going to be making sure that local health departments have a seat at the table during discussions about this, and making sure that we are able to plant some clinical providers within local health departments through this program, because the more clinical providers we have at local health departments, the more we can help to provide, prevent hospital readmissions, keep people out of the hospital and save those costs. So I think that's a big thing. Our biggest concern really is if the next public health emergency comes through and we already have a shortage of healthcare workers, you're not going to be able to tap every local health department to say, hey, do you have nurses who can come out and help with testing or help with vaccine administration? Because they all left after the COVID pandemic. And so, just being aware of the fact that the local health department's not being able to provide those clinical services is really important. I think we also need to be really thoughtful when we're looking at new statutory requirements for local health departments to make sure if there is a new requirement that they have to take on, enforcement of certain illicit products or, new mandates or lowering elevated blood lead levels, we need staff to do that work. It's really important work. We want it to get done because that is prevention. But we really need to focus on the workforce and attracting people to those public health prevention jobs. So, those are the key things that we're thinking about, could be a downstream driver from HR 1 impacts that we really are focused on and concerned about.
Thanks, Sarah. And I think we have another participant asking, what is the outlook for New York's Rural Health Transformation Program application? So obviously it is I think New York has already been given some funds, correct? Or the initial?
Yeah, New York State has received $212 million in rural health transformation funding. And I believe it's going through the process of opening up applications so that communities that are eligible to apply can submit their proposals for funding.
Yeah, I know our members are anxious, appreciating that it takes time to set this up. It's a lot of money to get out the door and figure out how to do that. And I know there's some language in the tied to the budget to make it easier to get the funding out the door as well. But our members are really looking forward to learning more about the opportunities and partnering, outside of just brick and mortar hospitals, to partner to strengthen healthcare in our rural communities.
And there's a question here, Sarah, that I can take an answer at, and you can jump in if I've missed anything. But there's a question about in regards to rural healthcare? Do the county health departments aggressively promote the value of the pension benefit? A pension can be life-changing in rural areas. And so I can answer that unequivocally of yes. But that would lead to a completely different panel because there is a state workforce shortage in general as well. It turns out that when you're 20 something now, despite all of the adults, and not that they're not adults, but those who understand the benefits of healthcare and pension explain to you how important a value that is. Sometimes it's hard to get people to realize that a pension 30 years from now is going to be very beneficial when they're getting an offer for a salary that's higher immediately, right? So it's always the challenge of striking that balance of how do we incentivize individuals to take the state and local jobs that come with the pension and the healthcare that are some of the gold standards that exist, but you're not making as much money. And it turns out sometimes when you're 20 something, the money today seems more logical than the money tomorrow, which it took us all a long time probably to learn that. But anything any of you want to add to that? But I think that is one of the challenges we see as well.
And not to get too off track here, but I will also kudos to Governor Hochul because the New York State HELPS program has been significantly helpful, and I know she's been continuing that over time. That's a program that allows government workers to be placed in hard to fill positions without having to take the civil service test or have to be hired contingently until they pass that exam, which can be a deterrent for accepting those government jobs. So.
Great. So we still have a few more questions in here. We've got about 5 minutes left. So let me ask one more, and then I'll try to end on a positive note, a positive question, give some hope maybe. And I'm just looking through the questions that we have to make sure. And yeah, so we have a question about sort of the fraud investigations and why they're targeted on these systems. And is there anything the state or county health agencies can support they can get from their providers or vendors in terms of functioning in a system that's trying to address the fraud? I'm not doing a good job of summarizing this question. So where are the fraud investigations focused on within these systems? I feel like we're missing maybe a big, so obviously there's been a lot of news lately about sort of investigations into fraud within the system. And Erin Kate, I think you already addressed this a little bit, but anything you kind of want to add on that front and why it's being targeted with your crystal ball?
Yeah, I'm not really sure exactly what the question is, but if the question is, where are the fraud investigations within the state targeted? The Office of Medicaid Inspector General puts out every year, and it's on their website, what their work plan is going to be for the upcoming year. So it puts out publicly the areas that it will be focused on in its audits and investigations and recoupments, as well as information about those programs and what their audit protocols will look like. So that will give you an idea for each year of where those fraud investigations are within those systems.
Thank you. Yeah, so last question then, because we have less than 3 minutes left, and last question, any final thoughts any of you want to share with the panelists? But we did get a question sort of talking about we're all, what happened with HR 1, we're all looking to see what future impacts there will be. And the question is there anything positive that's coming from the federal government that we're hopeful for that might be helpful? And I want to say that hopefully the answer to that is yes, but even if it's not just, what's positive, are there other things in the pipeline that we're looking for that may have an impact on New York? So we'll do the reverse order of how we started. How's that? So we'll let Stephanie, you want to take that one first? Anything positive you're looking for?
Yeah, I mean, I think the Rural Health Transformation Program is positive. Obviously it doesn't make up for all the other hits, but it's a really significant investment. And I think a lot of really good things can come out of that for healthcare in our rural communities. I guess the other thing I would say, trying to find a positive spin on all this is there are a ton of really committed people working in healthcare today who figure out a way to make things work. You look at the pandemic, for an example, a really difficult time. And there were good things that came out of that. And I won't necessarily say, good things will come out of HR 1. I know that really dedicated, smart people are thinking every day about how they can continue providing services to their communities at the levels they are today, and figure things out, when it comes to workforce, what are the creative ways to make sure we have enough workers. Technology continues to advance. I know AI, sometimes there's pluses and minuses of AI, but there are opportunities there. So I think in healthcare and in government, people just put their nose to the grindstone. I think that's how the saying goes. Maybe not quite right. And, we figure things out. So I'm sure we'll all continue to do that.
I would just add, since the beginning of last year, we've seen quite a few instances of the federal government's placing stop work orders on contracts. And no, that's not the positive piece that I'm about to get to. But in some of these cases, or most of them, right, we've seen either legal action taken place to stop that from clawing back funds from states. And then in other instances, the activists have really, really been loud and said, hey, you can't just put a stop work order on this, because we have people who are actively in the community doing work, responding to emergencies. So that really defeats the purpose. And then they rescinded that pretty quickly. And so I would say, even though it's not great to have an immediate stop work order happen, and it creates a lot of uncertainty, it did get overturned in a few instances. Our public health infrastructure funding, and then some of our mental health funding streams that happened with. So that was good, and hopefully it will lead to less of that happening in the future, but we shall see. And then I would also just say we definitely in public health have a brighter spotlight on our career path. And I would encourage any upcoming attorneys to think about becoming a public health unicorn, is what we call you. We need lawyers in local health departments, at state level departments of health, right? Those are really good career paths that actually have a really great economic return on investment for communities. Hiring a public health intern locally can bring in a great deal of revenue to your county.
Erin, Kate, any final word?
Well, I'll be very brief. And this is a tough one for me, because when you've devoted, your career to public programs and coverage, it's pretty tough to find anything positive about HR 1, which really focuses on removing eligibility for your younger, healthier populations just based on their immigration status, which of course, from any statistical standpoint, means that costs are going to increase as well as coverage be lost. So hard to find good in that. But I will say that even though New York really has been a leader in, how to root out fraud, waste, and abuse, putting a national focus on removing fraud, waste, and abuse from a taxpayer program is never a truly bad thing. That's as close as I can come, Amy.
I'll take it. Yeah, I think it's tough, but I think
It's tough.
if nothing else, people are talking about the issue as well, and it's sometimes the policy stuff. Like I said, we eat, live, and breathe this. We like talking about it. We're making people have conversations maybe they don't want to have, and I'm not sure that's a bad thing. So maybe that's another silver lining. The tough conversations have to happen at some point. So we're having them now. And on that, we want to thank you all for joining us for today's tough conversation, but we appreciate the time and attention. Thank you to Erin, Kate, and Sarah and Stephanie for your expertise. And thank you all to our participants for attending. So thank you all. Have a good day.